Hi, Gary. I'll welcome you to get us started.
Very good. So good morning, everyone. A special welcome to those of you who are joining us for QI Power Hour for the first time. This is Gary Tier, Chief Executive Officer at the Health Quality Council in Saskatchewan. QI Power Hour is a free monthly WebEx offering hosted by the Saskatchewan Health Quality Council that provides opportunities for colleagues across healthcare as well as other industries to hear from local and national improvement experts on a variety of quality improvement related topics. Just a reminder that following today's session, a recording of the event will be posted to our HQC website, so you can share that out with colleagues who are unable to join us in person today. We also invite you to check out our recordings and presentations of past sessions. These are available on demand at the address listed on your screen. While you're on our Health Quality Council website, we also invite you to sign up for our distribution list. That will help you to ensure that you receive regular invites to all our upcoming QI Power Hour sessions. Over the last number of months, we've been delighted to see how our QI Power Hour has continued to spread throughout our province, within the provincial healthcare system, as well as to those organizations in Saskatchewan who have an interest in quality improvement. We've also begun to see spread to other organizations within Canada and even internationally. Again, welcome everyone to QI Power Hour. Now I'm going to pass it over to Chelsea Schwartz, who's a provincial improvement consultant here at Health Quality Council, to cover a few of the interactive functions involved in today's webinar. Chelsea?
Thanks much, Gary. Hi, everyone. As Gary mentioned, I just want to remind folks of the different ways that you can contribute to today's session. The first feature I want to highlight is the annotation function. You can access this function by clicking on the pen icon on the top left hand of your screen and then selecting the arrow icon. So just to give everyone a chance to practice this, I'll welcome you to click on the map and indicate where you're joining us from today. Thanks, Heather. So we have some representation, some good representation from Saskatchewan, it looks like, all the way out from BC, Pat Rutherford joining us from, I believe, IHI, actually. Excellent. So we have some good spread across the country, a little bit of international representation. Thanks so much for your participation already. Thanks, guys. So the second tool that I want to highlight today is the chat function. So you can access this by clicking on the chat bubble on the right-hand side of your screen. We encourage you to share your questions, comments, and ideas throughout the presentation. We'll have some time dedicated to Q&A at the end of today's presentation, so we encourage you to send all of your questions to all participants so we can all join in the discussion. If you're experiencing technical difficulties, you'll notice within the panelist listing, we have a rep signed on as HQC Tech Support, and that's Adrienne, and she'll be happy to help you with any technical concerns that you're having. So let's take a moment to practice this function by typing in the chat the name of the organization you're joining us from. Prairie Mountain Health, welcome. Island Health BC, Lloydminster, eHealth Saskatchewan. Now that we're combined into one health region, we have quite a few representatives from the Saskatchewan Health Authority. So welcome, everyone. Alberta Health Services, excellent. So it looks like everyone has the hang of this. That's excellent to see, so we'll welcome your participation that way today. We'll also welcome you to tweet out your learnings and your insights throughout the presentation today using the handle HQCSask and the hashtag QI Power Hour. So with that, I'll pass it back over to Gary, who will welcome our speakers for today's session.
Great, thanks, Chelsea. So we have a really exciting topic for you this morning, Connected Care, the Saskatchewan Journey Toward Improved Patient Flow. And our two speakers are Graham Fast and Sheila Anderson. So Graham is the lead for the Emergency Department Waits and Patient Flow Initiative at the Health Quality Council in Saskatchewan. In this role, he leads a cross-organizational team in developing and implementing strategy and policy to address the system barriers to patient flow. Graham has clinical and administrative experience in both private and public sectors of healthcare. And Sheila is currently the Executive Director of Urban Primary Healthcare Services within the Saskatchewan Health Authority. Her work is focused on ensuring services are community designed, client-centered, and team-delivered. Sheila is highly committed to strengthening primary healthcare and community services. She has participated in the strategy program from Queen's University, is Six Sigma certified, and a graduate of the Saskatchewan Lean Leadership Program. So, over to our speakers.
Okay, well, good morning, everybody, and thanks so much, Gary and Chelsea, for this great opportunity. I know Sheila and I are really looking forward to today, and we're really grateful for the opportunity to present this to such a diverse group of stakeholders across the country and indeed even internationally. It's an excellent opportunity. Just so that people know, Sheila and I are actually not in the same room this morning. I'm in Saskatoon and Sheila's in Regina. We have co-presented before, most recently at the Canadian Home Care Association conference in Halifax in November. But this will be the first time that we've actually presented from separate locations, so we'll see how that goes. I do want to start off with a little bit of an apology this morning, just to those stakeholders from Saskatchewan that may have heard us or heard me speak before on the Connected Care Strategy. Some of it will be definitely review material that you've heard before, but I think that for many of you on the call, this will be the first time that you've heard some of the information that we'll share with you today around the Connected Care Strategy. Our intent really is to share our journey with you, and it really has been a journey. It's really been a bit of an evolution from the E.D. Waite's initiative to this next phase of work of what we're calling the Connected Care Strategy. And we've purposely and very intentionally given the Connected Care Strategy its own identity because as you'll learn and as you'll hear today, it will outlive the initiative that is currently going on around reducing emergency department wait time. This is a multi-year transformational strategy that we're embarking upon. You're going to hear from me very much from the strategy development, the theory, the theoretical perspective, and then I'm going to turn it over to Sheila, who will really speak to you on behalf of what that looks like in terms of practical application around implementation at the point of care. I do want to qualify that we are in our infancy on this multi-year journey. So we're starting to see pockets of really good work emerge around the province related to connected care, and we're starting to see some of the outcomes that you're going to hear about later this morning. But we're only scratching the surface, so I don't want to leave the impression that we've got this all solved. We're certainly just figuring out, but we're really quite excited about what we're starting to see. So I'm just getting Chelsea to help me with the slides here. Great, thank you. Okay. So I always like to start off by sharing this image with stakeholders when we're doing this presentation, because this is really what our team was originally tasked with, and that is the elimination of wait times in our emergency departments in Saskatchewan, or creating empty waiting rooms, if you will. The work really stems back to the 2008 Patient First Review that was a government-commissioned report in Saskatchewan where over 4,000 patients and families were surveyed and interviewed, and one of the primary complaints or issues that they were facing was long waits in emergency departments. And our Premier Wall, challenged our health system and said, you know, we need to do better than that, and challenged us to eliminate wait times in our Saskatchewan emergency departments. So, as I say, our original goal or our mandate was that no patient would wait for care. And you can imagine, I think, when we're out meeting with stakeholders, how we were met with, obviously, skepticism. There was lots of discussion around, well, how do you define a zero-wait environment in the emergency department? Is that a realistic or is it a desirable or achievable goal? It didn't really matter. What was really great about it is it was a stretch target and an attention getter, and it led to lots of engaged debate with stakeholders across the province. And as we got a little smarter and as we started to understand the problem in a little more detail, we realized, well, no, it's not really a realistic or achievable goal. So we redefined our goal, and as it stands, our goal is that by March of 2019, we're looking to see a 60% improvement in our wait times provincially. The one thing that was clear right from the beginning in engaging with stakeholders is that the scope of what we were trying to do needed to be the entire continuum of care. This wasn't about changing or intervening or doing things differently in emergency departments. This needed to be upstream and downstream. So wait times in the emergency department. It's a system problem. So in a perfectly functioning system, what you would see is that patients would be self-managing their care in the community, hopefully living independently. When an episode, a health episode comes up, you know, they're consulting with their family physician or their primary health care team, getting the supports or care they need to remain independent and at home in the community. If by chance the episode requires a visit to hospital, they either ambulate or are transferred in by EMS to the emergency department. In an ideal system, they would be seen by a physician and nursing team upon arrival to the emergency department, and they would receive the appropriate care and be discharged home with the wraparound supports that they need in the community to stay away from the hospital. If by chance they needed admission, they would get into an appropriate hospital bed immediately upon admission, and they would have an appropriate length of stay. But as soon as they were ready for discharge and no longer required the intensity of resources of acute care, they would be discharged home, and again, services would be wrapped around them in the community to keep them out of the emergency department, out of the hospital. That's the ideal healthcare state. Obviously, that's not what we have. What we have are fragmented information systems that don't talk to each other, and so information flowing with the patient across care teams is always a challenge. We have high volumes of patients that are coming into the emergency department. You know, we use the word inappropriate. I don't like that word. It's not that it's inappropriate, but they're patients that should and could be cared for in more appropriate settings in the community. So things like family practice sensitive conditions and our low acuity CTAS 4s and 5s that should be seen elsewhere. In Saskatchewan, our volumes are just under 50% of low acuity patients entering our emergency departments. That leads to long wait times in the emergency departments, long wait times to see a physician, and also long wait times to get into an appropriate bed if they require admission into the hospital. We have hospitals that are constantly operating in overcapacity. There aren't many days where our tertiary hospitals are under 100% capacity. And that's because we have lots of patients that have gone through their acute phase of their care. However, we don't have the systems and services in the community to safely transfer their care. So what this really leads to is a system that operates often in a state of gridlock, where patients aren't moving and they're staying stuck in their location of care. Frustrating, and I know we're certainly not alone in Saskatchewan. This is indeed a national problem, international problem. So that's the environment in which we started to do some thinking around. So our current reality, well, in Saskatchewan, 30 to 50% of our acute care beds are alternate level of care, or ready for discharge, as they're often referred to, or delayed transfers. We have high volumes, as I said, of low acuity presentations to our emergency departments. We have higher than the national average volume of avoidable admissions for chronic disease. We have high 30-day readmission rates and 7-day revisit rates to our emergency department. And as I said before, we have many barriers around the timely flow of information across our continuum of care. So that's the reality in which we are currently existing and which we are trying to implement change. Another way to look at this, another simple way of looking at factors that impact emergency department wait times is really input, throughput, and output. In other words, you can kind of think about it as front door, house, back door, if you will. So the presentations coming to the emergency department and hospital, the efficiency of how we manage patients through the emergency department and hospital, and then on the our ability to discharge and move patients out of the institutional setting. But this leads to where do we focus our attention then? So if there's lots of opportunities here to impact patient flow, where do you really start to focus? Or if you think about it in terms of financial investment, we obviously have very limited incremental resources financially to invest, so how do you make best use of those dollars in terms of sequencing, in terms of activity that you invest in? Well, when we launched our team was put into place back in 2013. The economy at that time took a bit of a turn, and we didn't have a large number of dollars to invest. And when we look back on that, we consider that a blessing in disguise, because I think at that point, had we been given a sum of money, we probably wouldn't have known exactly what to do with it, and I suspect we would have invested in areas that probably wouldn't have seen the greatest gain. So not being able to make big investments, this really allowed us the opportunity to do a very thorough root cause analysis that was specific to our context in Saskatchewan. And so we certainly went through the traditional methodology of literature review, environmental scanning to look at, you know, other Canadian, other international jurisdictions that have had success around patient flow. We were able to engage with stakeholders nationally and internationally. But one of the things that I think we did that was quite unique is we also invested in health system modeling. So I know that there was a QI Power Hour back in June of 2017 that a couple of my colleagues, Adrian Danlou and Yuan Tian, they did around health system modeling. So I'm not going to go into great deal today, but again, if for those of you that didn't see that presentation, this is really a computer-based simulation modeling that allows us to do what we call virtual pilots, or run what-if scenarios. So it gives us the ability to look at virtual interventions without actually making investments in the system. And the inputs going into the model, of course, are evidence and data, and we're able to use our local health system data and a model of our own hospitals in the Saskatchewan so that, again, we can really contextualize the solutions to the Saskatchewan context. So we have modeled, we've used this tool a lot. We've modeled a lot of different scenarios, and I'm just going to summarize them very briefly here. But what we did is we modeled, first of all, what if we could take those low acuity presentations and divert them away from the hospital, away from the emergency department? So if we could take our family practice sensitive conditions, our CTAS 4s and 5s, and move them away into a different care setting, what would happen to wait times in the emergency department? And actually what the modeling shows, and it confirms from other jurisdictions that have attempted this, that it has a very low impact actually on your wait time metrics in the emergency department. But when you actually look downstream, we modeled scenarios where we were able to reduce our ALC, our alternate level of care days, or our delayed discharges, our delayed transfers, and if we could remove those patients and care for them in the community, that starts to actually have quite a dramatic impact on wait times. We also modeled a modeled team-based care in the hospital called accountable care units, which I'll talk to a little bit more in a few minutes. But again, that also had a higher impact on wait times. And then we also modeled ideal transitions of care, which again I'll speak to a little more detail here in some coming up slides. But really what all of these things showed us is that the primary driver of the emergency department wait time was hospital occupancy rates. And interventions and activities that could reduce hospital occupancy, either through reducing admissions, reducing patients, days, or so length of stay, or reducing the number of ALC patients. Those are the things that really, in theory, has the most dramatic impact on emergency department wait times. So again, it really validated what many of our assumptions were and the things that we were learning from literature and environmental scanning, but we were able to specifically contextualize it to our Saskatchewan system. So when I talked about ideal transitions of care, this is work that was done by Burke and Associates in the U.S. that really looked at a systematic review of what are the domains that constitute ideal transitions of care that lead to lower revisit rates to the emergency department and 30-day readmissions to hospital. And I won't go through this in huge detail, but you can see that there's 10 domains that really constitute an ideal transition of care. And when those are put into place, it leads to a reduction in length of stay, which then reduces occupancy rate, and that's how you see the impact on emergency department. So our thinking was really then, well, okay, do we just send out a change management package and say around transitions of care and say, okay, our work is done here, and then we thought, well, that's obviously simple, but it wouldn't be sustainable over the long term, because we had lots of other work foundationally that needed to be put into place before we could do that. So the right course was obviously far more complex and far more winding road, because we really believe that in order to have if you think of the concept of the bridge or the analogy of the bridge, we needed to strengthen the two pillars of the bridge. So we share this image as being sort of the framework for the connected care strategy. So the essence is what we've branded high-quality care transitions, or as Burke and Associates called them, ideal transitions of care. And then on each end of the bridge, we have these high-functioning teams in community and hospital that are enabling the processes to ensure these high-quality care transitions are occurring. So the patients are safely transferred from one care team, one care setting, to another. So the connected care strategy, I think at its essence, it's really, as it says here on the slide, it's about enhancing team-based care in hospital and community, and then using evidence-based approaches for the transferring of patients from care team to care team of what we've branded high-quality care transitions. So this is what our definition of our connected care strategy is in Saskatchewan. And I would say that we've been on a journey. So it's a journey of discovery. Really, what started out as being a real focus on emergency department wait time reduction through root cause analysis and through our health system modeling, it was really clear that there's no way to achieve that without focusing on hospital occupancy. And so what we learned was that the solutions that impact hospital occupancy, again, aren't so much in the hospital as they are in the community. So we had to focus in both settings. So it's about strengthening team-based care in a hospital, but most importantly, it's about the community pillar and strengthening the team and the processes for ensuring safe transfer to the community when it is appropriate. I would say that this is our current state of what our system looks like, and actually the patient and family I've got connected in those bubbles there, they shouldn't be. Our current state is that, oh, I'm sorry, this is our, I'm just going through my slides here. So that's what I'm looking for. Thank you very much, Chelsea. So this is our current state, where I think the priority of our healthcare system tends to be on institutional care. The community is oftentimes administratively and in terms of investment of activity and dollars is an afterthought. And the two systems aren't very often connected, and oftentimes patients and families are left in the middle and left on their own to navigate their own transfers or navigate the community once they are transferred. And again, we are looking to a paradigm shift here, where we are trying to make the focus on our community care services so that hospital care is only episodic and that the patient and family is safely transferred from one care setting to the other, so that the two teams are linked. So this is a visual representation that we often use. Community care intentionally bigger than hospital care, patient and family connected, the teams are connected, and the bridge representing high-quality care transitions. So what does connected care look like in the hospital? So again, we're talking about strengthening team-based care in both hospital and community. I'm going to start off with the hospital. In the hospital, well, what we talk about, and I shared with you that we modeled the accountable care unit model. The components of an accountable care unit are that there are nurse and physician co-leadership on a unit, and that there are dedicated unit-based teams. So in our current paradigm, physicians and oftentimes allied health professionals are going across multiple units, sometimes multiple hospitals, to care for patients. In this model, physicians and allied health professionals are dedicated to a single unit. And on that unit, there are very structured processes for the way communications occur amongst team members and with patients and families. So there's processes that are standardized for shift handover and transfers of patients. And there's a structured interdisciplinary bedside rounds occur at the same time every day. So it occurs at the bedside with patients and families, and the conversation occurs with them, not over top of them and not around them. And it's really the team's ability to understand the data that they have, and in this case we talk about our ALC data because it's so critical to our experience in Saskatchewan at the moment. So what does connected care look like in the community? And you're going to hear a lot more from Sheila what this really looks like on the ground. But some of the same concepts are what we're trying to achieve, and that is that, first of all, that the teams in the community really need to understand the communities in which they operate. So it requires detailed data analysis. What is the burden of disease? What's the service utilization? What are the existing services, et cetera, so that they really understand the patient population that they're serving. And then taking a look at what your existing services are and try and meet your current demands. So load leveling your supplies across whatever geographical boundaries that you've established. It's about interprofessional team-based care. Where it's possible, co-location is always encouraged, and it's far more difficult, obviously, in the community than it is in hospital. But you know, we try to encourage it where it is possible. Physician leadership, of course, is always critical to any team, and then having defined boundaries for which the team is accountable for, so they really understand who it is that they're serving and who they're accountable for. And like I say, you're going to hear a lot more from Sheila in terms of what this truly looks like on the ground. So what are we trying to achieve? You know, I think if we start to think long term, and I think we have to acknowledge that this is a long-term goal. But what we want to achieve is a high-functioning primary healthcare system. But that system needs to be connected, it needs to be patient-centered, and it needs to be inclusive of all community-based services, so that we don't have siloed community services anymore, that they're all integrated. How are we going to measure and evaluate what we're doing? Unfortunately, we're probably like the rest of the country, that we are struggling with finding the right suite or set of metrics in the community to demonstrate our success. So right now in our infancy, what we're doing is we're looking at it in terms of what are the defects of a high-functioning primary healthcare system. And so the defects really are going to show up in our institutions, but they're around delayed transfers. So our ALC days are our number of ALC patients, so patients that are stuck in hospital, ready for discharge or ready for transfer and not able to move. Our acute care lengths of stay we're looking at. The number of family practice sensitive conditions that are presenting to the emergency department, so those patients that should and could be cared for in family practice. And the admissions for ambulatory care sensitive conditions that we believe are avoidable. Again, patients that should and could be cared for in the community. And then again, we're looking at our 30-day readmission rates to acute care and our 7-day revisit rates to emergency. And again, at the same time that these are all institutional metrics, we're looking at currently how we're going to, if we're seeing a reduction in the utilization of acute care and services, what are the corresponding set of metrics that we're going to see in the community? And our team is actively working through that process. In terms of some of our results, I'm going to leave that to Sheila to speak to. So with that, I will pass it over to Sheila.
Thank you so much. Can you hear me out there?
Yep, we can hear you.
Perfect. Okay. Well, thanks so much, Gary and Graham and Chelsea. And good morning, everyone. Such a pleasure to be able to present to you today, a real honor. So as Graham said, I just wanted to spend, I think I've got my timer on here for 15 minutes because we certainly wanted to leave some time at the end of the session today for some Q&A. So my presentation will focus on just sharing how we've brought the connected care strategy to life, mostly in the community setting and certainly within the Regina area of the Saskatchewan Health Authority. So I thought I would share a little bit about how we got started and why we did, what our model is to deliver on the connected care strategy, and what we're trying to accomplish. So speak about that upstream work and also that downstream work. I would agree with Graham that this we've done a lot of work in our area here in the last number of years, about 3.5 years, but there is certainly much more work to do to become fully connected and accountable. I always like to say that what I present today is certainly not just my work. I wanted to acknowledge the team here in Regina for all the work that they've done to accomplish the start of our journey through connected care. I also want to thank Graham and his team for the support that they've given us. I always, I've had the pleasure of listening to Graham a number of times now with the talking about the theory behind the connected care strategy, and it's such a good foundational piece to for us to continue to connect our work to. For many of you out there, excuse me, when we present out on our work, we often say, I'm sorry, we often say that this is not new work to many of you, and there's lots of great work going on across the province, across the country, and certainly internationally as well, too. So a lot of this work people are doing, and we're learning from them as well, too. Okay. So as Graham said, mentioned the foundational element of the connected care strategy is accountability. And so what we're trying to build out in, or what we've been working on is really changing culture around our accountability and community care for our patients and our families, for our staff, how it can be accountable to physicians, to our neighborhoods and communities, and certainly accountability at a system level. I think we've done a lot of work in the last several years to really increase the confidence of community care and to increase the capacity and capability of providing services, better services out in the community to meet people's needs. So certainly we have a big system and it's not always connected. And when we have a big system, and I think we often think about transferring or referring clients to someone else in the system or in the next step in the process. And when we do this, we really pass on our accountability to somebody else. So our work has really been about trying to take on the accountability for community services within community-based teams in a primary healthcare network model. So our story is about connecting communities and providers in team-based care and integrating them to better manage the needs of our clients at a community level, to reduce those referrals or handoffs to the next step, and to really create that culture of accountability. So we started doing our work and realigning and strengthening our community services in 2014, and it was to really address the voice of our clients and our families and our communities, and to really improve everyday healthcare services. So we heard and continue to hear a lot around lack of services or capacity to care for people in the community, lack of access to those services, so lots of long waiting lists, certainly lots of lack of connectivity or continuity between care providers. And with that, also a combined reliance on our acute care system, our overcapacity in our hospital, our long waits in the ER, our high bed days for alternate level of care patients, really led us to say we really wanted to look at how do we redesign our primary healthcare services so we can better serve patients in the community. And we adopted a model of primary healthcare networks. So a network is essentially, it's a geographical area where community-based care is delivered closest to the clients by small, multidisciplinary teams who know one another, the patients, and the community. So networks are accountable for accountable care teams providing community-based services such as home care, public health, chronic disease management, and primary care. So how we got started with our primary healthcare networks was the use of data. So we really used different sources of data to map out profiles of our communities. So we went neighborhood by neighborhood to understand what the healthcare needs were. Once we did this, we really defined our network borders, and in our QHR Urban, we have 4 primary healthcare networks. Many of our networks have neighborhoods with similar profiles. Each network is made up of teams that are connected. They're multidisciplinary teams. Multiple interdisciplinary teams make up a network. So our community-based teams are designed to meet the unique needs of each one of our communities. So because we had an opportunity to look at different data sources such as census data, hospital utilization data, we were able to understand what the unique needs of each one of our communities were, and then align our providers that are in community to meet those needs. So we realigned our providers, so our home care providers, our public health providers, our chronic disease management providers into individual teams that were located in neighborhoods, in neighborhood hubs. Graham talked about the importance of co-location, so we certainly co-located them into hubs or locations within communities so that they could serve clients closest to where they live in the team-based quick care. So we moved to a coordinated, co-located, and connected team-based care model to really create that culture of accountability. I like to show this graphic because it talks about what we're trying to achieve in each one of our networks. So the green parts of the triangle are really the capabilities that we're trying to develop in each one of our networks. So our networks are made up of community services, intermediate care services, and complex services. And we really view that acute and specialty services, as Graham said, as episodic care. So what we're trying to do through our primary health care networks is strengthen community services, intermediate and complex services, so we can provide that care out in the community, and that we can reduce the reliance on our acute care services. Certainly the way that we move people up and down through this triangle is really through those high quality care transitions and those best practices as we transition people in and out, and in between the services that we provide at the community level as well too. We've done a lot of our work, and the majority of our work has really been on strengthening the base of our triangle. So we're really wanting to strengthen our everyday services out in the community so that we're able to have the capacity to provide service, safe service out in the community. In the past couple of years, we started strengthening our intermediate and complex services. We have seen there's a lot of our clients that are in the acute care system that actually have intermediate and complex services that could be cared for out in the community, but they often sit in the emergency or in our acute care system. So we're trying to build more capacity within the community to have to provide complex care and intermediate services. And we've just recently launched a number of teams or built capacity in that way around our hotspotting teams. We have a seniors house call team, so our intermediate care services that are able to be responsive to clients who are either on the runway to getting into the acute care system or are able to be pulled out of the acute care system a few days early. If they do have a hospital stay, we can get them back into the community and work to keep them there or support them better in when they need some intermediate services and complex services. And the idea is to stabilize them in the community and then connect them down, farther down into the triangle to our providers that work in the bottom of the triangle, so providing those basic community services. So the way the network's designed is that we have providers that are working together. Providers that are providing intermediate and complex services are working side by side with providers that are providing those services of the everyday care needs. So one of the things that it's been a big change for us was combining our different service lines. So taking providers from each one of the community services. So I'll give you a few examples. So our home care and our public health nurses are now co-located within network hubs, working side by side, linking their services together. We have our primary health care and mental health counselors that are also embedded in those teams. So when we have team-based huddles and other activities that are designed to increase the accountability for the care that we need to provide for people in those networks, we have a really robust team that's able to meet the unique needs of each one of those clients and providing up and down that triangle so that we can focus our efforts on keeping people in the community as safely as possible. So I just wanted to have a series of slides that just talks about kind of how we operationalize the model and how we are accountable to each one of these groups here. So really, what are the benefits for our community? So I wanted to start with that. So because we understand and have looked at our data and really understand the unique needs of each neighborhood, we're able to specialize our services for that. So many of our neighborhoods, some of our neighborhoods that have our most vulnerable populations or populations with really high needs such as mental health or addiction services, once we were able to identify these neighborhoods, we were able to realign our providers to meet those needs. So we have neighborhoods that have unique needs in mental health and addictions, and we would have a higher complement of primary health care providers that meet those needs there. We have other communities that have young families, so we were able to look at our data and able to deploy our health nurses or reassign our our public health nurses to meet the unique needs of individuals in those neighborhoods. So I think in the past we had previously taken our resources and had just evened them out across the city. This model and how we designed our primary health care networks was an opportunity for us to really look at the unique needs and assign our providers based on the needs of each one of those communities. So also the primary health care networks are starting to connect to community agencies and supports. So we know there's a lot of great work that are going on in our communities and a lot of people that are interested in connecting to our services to better enhance our services. So we have many of our providers out in community buildings and connecting with community agencies to work together to better support the patients in those communities. Because our providers are now co-located in neighborhoods, there's an improved accessibility to health promotion, prevention, chronic disease, and mental health services close to home. And we're really building that culture of ownership of the residents that reside within the network borders. So a lot of our work over the last year has been talking about what are the needs of the individual people that live in your neighborhood that you're responsible for, and how do we take ownership of caring for them or providing services to them regardless beyond what we had done in the past. I think we often work in these buckets and say, I provide a home care service and I go in and do I'm very tasking. So we're trying to ask our providers to look beyond that. We're building a culture of what are the needs out there and how can we collectively as a team of providers meet that need of that client. So, of course, we're being accountable to patients and families. So we've had a number of improvement events over the last several years where we've had an opportunity to design our model with and for our patients. Certainly, we're seeing an increase in our consistency of care for our providers. We've realigned them into these small geographical networks, and so they're able to get to know their patients better and provide more consistent care. Our care has been more coordinated as well too. So we have implemented daily huddles, more handoffs, and many opportunities that our interdisciplinary and inter-service teams are able to meet on a daily basis, multiple times a day, not only to talk about demand and capacity, but also to talk about the real care needs and problem solve together as a large team to be able to address everyday problems and everyday issues and really enhance care for clients beyond just the tasking. We've really saw timely resolution of care concerns. Those care concerns come right back to a huddle every day where we have an opportunity for the team members to talk about what's happening with individual clients, and because they have a broad team around them, we're able to address those problems really quickly. We've developed a community paramedicine program that's connected not with our EMS programming, but in our primary health care programming. So we have paramedics that are also attached to community teams and are huddling with our home care and public health and chronic disease management folks contributing to the service delivery model in the networks. We've really moved to providing post-hospital follow-up visits and calls, and we're coordinating our care better with our family and physicians as well too. So our model has really allowed us to be more accountable to our providers as well. So what are the benefits for the people that we work with? And I think this is where we've seen a lot of gains in the last couple of years. And certainly our teams are co-located, and our providers feel like they have a team and they have support and they can problem solve at a team level. Prior to our network model, we often heard of our providers working in isolation. So many of our providers were going into the same home to provide the same care, but the care wasn't coordinated and they didn't know the other provider. So they have access to multiple different types of service providers, again, like those a nurse practitioner or a community paramedic, providers that they wouldn't have access to before, that they have access to on a daily basis. We have this dedicated time to do case conferencing. So one of the big benefits of working in this team-based care is the opportunity to share the workload through daily visual management. So we have a lot of daily visual management boards and talk a lot about demanded capacity for the day. So when a care provider is unexpectedly away for a day, how are we becoming the broader team accountable for the care that they provide in that day? So that shared workload, certainly co-locating providers in a small geographical area has really decreased their travel time, an opportunity to work at the top of the scope, which has been really beneficial and something that our providers have really thought of as a great benefit. Certainly that mentorship and the support of a broader team. So they're really building that culture of accountability to each other and that culture of accountability, again, to clients and the families within the network as well, too. So there's also certainly benefits to our physicians, and this is an area that we're just starting to explore and that we need to continue and make a lot of gains in this area. So currently right now we do connect our services into physicians. Most of our physicians in our networks and our neighborhoods are fee-for-service physicians, and we're looking at creative ways of how we connect into them. Our model has always been kind of, I say, an all-inclusive model because we work with both fee-for-service physicians and non-fee-for-service physicians. And looking at, we've done a lot of work in the last couple of years with having visiting services within providers, within physician offices. So many of our providers are going into physicians' offices providing counseling services or chronic disease management. We even have respiratory therapists out in the community that are in physicians' offices providing spirometry and such. One of the things we invested in early in our primary health care model was a dyad model for our primary health care urban as well as our rural services as well too. So that co-leadership has been essential. You heard Graham talk about it in the accountable care unit. Really essential in terms of we know that family physicians and community are such a big part of primary health care, and in fact they're the ones that provide the majority of the primary health care out in communities, and we need to find a way to connect our services. So having the opportunity to have a family physician that's administrator dyad lead has really been beneficial in terms of getting our family physicians in the community connected to our work and finding ways that are meaningful for them, for us to support them in their providing primary health care as well too. So certainly moving into shared care planning with physicians as well, and I spoke about the visiting services in physicians' offices. We've also had a number of events where we've had a great family physician representation at co-designing some of our community programs, and we've recently launched a COPD community pathway where it was co-designed with both patients and our family physicians, and has been a really big success. So I just wanted to spend a minute talking about accountability to the system and how our model is accountable to the system, to the larger system, which is something that we're continuing to evolve and know that it's very important when we really excuse me. We're really connecting our services through high-quality care transitions. And this model has led us to a greater understanding of flow from acute to community. So we have had many providers now that are going into the hospital, community providers that are connecting in with hospital teams. So they're in hospital either case finding and pulling people back out into the community, or working with those community teams rounding. Our accountable care units have a daily round, and we have now community team members that are going into the rounding in our accountable care units, working with those teams through discharge planning, those high-quality care transitions such as 24-hour or 48-hour either visits or phone calls post-discharge. We're really building a reliable and consistent community care. One of the things that we've been committed to over the last 3.5 years is to move away from 5-day-a-week community care to 7 days a week. So we've moved many of our provider schedules from 5 to 7 days, and we only hire people into a 7-day rotation so that we can really have that consistent, reliable care out in the community, because we heard loud and clear from our acute care colleagues that unless it's reliable and consistent, they don't have a lot of confidence in community care. So also our Regina area has really made a commitment to invest in community care to sustain the system. So we've had a real commitment from our senior leadership team all the way up and down our organization to make a commitment to invest in building the base of that triangle and strengthening our community services. So we've been really fortunate in getting some investments over the last couple of years as well too. So this is my last slide just to talk about outcomes. So certainly at a network level, we're really seeing increase in consistency of care, increase in units of service, so that increasing our capacity and even optimizing our provider time, so increasing our direct care time. But we're really seeing some early indications at a system level as well too, and I like always to be really cautious before I'm talk about some of these system level improvements or these early indications, because there's a lot of effort in our organization around patient flow and our ED weight initiatives, and there's many people that are contributing to it, primary health care being one, but we're really starting to see some system level improvements around decrease in emergency visits, certainly decrease in CTAS 3s, 4s, and 5s, really nice trending around our decrease in 7-day revisit rate, certainly a decrease in our time waiting for an inpatient bed, and our length of stay of admitted patients as well too. So those are really good signs that our system is starting to do exactly as Graham mentioned the connected care strategy is aiming for, is to really strengthen community services and decrease that reliance on acute care as well too. So I think I'll end there, and I'll put it back to you, Chelsea.
Thanks, Sheila. It's Graham. So I'll just, unfortunately, it looks like we're not going to have a lot of time here for questions. So I just want to make sure that people have, if you have questions or you'd like to have some discussion, we really encourage you to reach out to either myself or Sheila, or we'd be, I think, happy to arrange a time where we could meet together with you.
There was a really good question I saw posed from the Ministry of Justice around the importance of cross-sectoral community strategy, and I think it's a really important discussion that needs to occur. This is Connected Care is about breaking down silos, and I think that's another silo that needs to be broken down into the future. I do want to just end by saying a huge thank you to Sheila, a huge thank you to the team in Regina, but also a huge thank you to other teams across the province. Much of this strategy has come from what we have learned from teams that are operating at the point of care. Our rural colleagues in Saskatchewan, oftentimes when we present this, they say, this is what we've been doing for years because we have to do this, and I think that's so true. We've learned so much from the people that are at the point of care right now, so just a huge shout out to all the work that's going on in Saskatchewan. And with that, I'll pass it back to Chelsea to close.
Thanks so much, Graham. Thanks everyone for joining us today, and recognizing that we have gone 1 minute over time. My apologies. I just did want to take the opportunity to highlight our next monthly session. So it'll be Friday, February 16th. Same bat time, same bat channel, 9:30 to 10:30 a.m. To register for that event, you can head to our HQC website. We'll be welcoming one of our internal data analysts, Merrick Osman, who will be speaking about some of the data analysis driving some of our system-level planning with a presentation on high-cost users. So with that, you'll notice that at the close of your WebEx, it'll launch a survey. So we welcome you to take a few seconds to provide your feedback on your experience today. Thank you and happy Friday.